Vanakkam. In this video session on the management of ulnar nerve palsy, we are actually coming to the dramatic part, the dynamic tendon transfers. Yes, dramatic and most satisfying if the correct tendon transfers are chosen and correctly done. But there are so many of them. How do we choose which tendon transfer to be done? It is quite simple if we understand the basic principles about what each tendon transfer does and how it helps in improving the function of the hand afflicted by ulnar nerve palsy. And we shall see all about these in this video. Dynamic tendon transfers are basically procedures that move structures. So a tendon transfer uses a muscle to replace the function of another muscle that is not working, and it has got prime importance in the management of ulnar nerve palsy. And why is it so important? Because they do not just correct the deformity like static procedures, they replace the paralyzed muscles and actively motorize joints. They restore motion or balance to a hand impaired by absent function, and they add strength to the movements. We shall be learning about these important dynamic tendon transfers, but before that we need to learn three basic concepts. First of all, we need to understand that the basic requirements in the recipient hand must be fulfilled before planning a dynamic tendon transfer. The joints should be soft and supple. The patient should understand the procedure and willing to undergo the therapy that is required post-operatively. For more details about these basic requirements, please click on the icon above. Secondly, we need to consider the resting muscle fiber length and the tension fraction of each of the muscles that are involved so that we can plan a correct tendon transfer. For instance, the resting muscle fiber length of the adductor pollicis is 3.6 millimeters and the tension fraction is 3.0. We shall now see the features of some of the muscles that can be used to replace this muscle function. The FDS muscle has a good muscle fiber length and almost equal tension fraction. The ECRB2 has a good fiber length and a good tension fraction which is compatible with that of the adductor pollicis. Hence, these two muscles can be ideally used as tendon transfers. But the palmaris longus, though it has a good muscle length, the tension fraction is very small and hence very weak. So it can be used, but it would be a very weak transfer. The third and most important concept to understand is that when we plan a dynamic tendon transfer, there are 3 points that we need to understand and plan. The motor or the muscle that we are going to use, the route that is going to be taken, and the insertion that's going to be given. In ulnar nerve palsy, the motors could be finger flexors, finger extensors, wrist flexors, or wrist extensors. And as far as the routes that these motors are going to take are concerned, there are only two important points. The tendons may cross the metacarpophalangeal joint, in which case they must go volar to the deep transverse metacarpal ligament, as we need to achieve flexion at the metacarpophalangeal joint. If the tendon has to cross the wrist joint, we need to remember that wrist movement affects transfers, because if it crosses on the dorsal side, it will slacken with wrist extension, and if it crosses on the palmar side, it will tighten with wrist extension. Irrespective of the motor and the route, the point of insertion has a big role to play in deciding what movement is going to be achieved by the tendon transfer. There are three main points of insertion: the proximal phalanx or A1 pulley, the lateral bands of the fingers, or the A2 pulley. When the insertion is on the proximal phalanx or A1 pulley, the main function achieved is flexion at the metacarpophalangeal joint. When the insertion is in the radial lateral bands of the fingers, along with flexion of the metacarpophalangeal joint, extension of the interphalangeal joints is also achieved. When the insertion is on the A2 pulley, very powerful flexion of the metacarpophalangeal joint can be achieved. So, having understood the basic concepts in tendon transfers for ulnar nerve palsy, we need to know what tendon transfers have to be done. But this question can be answered only if we answer the question of what functions are to be achieved. In fact, there are 5 basic functions that we need to achieve or restore in a hand affected by ulnar nerve palsy. Correction of the claw deformity, restoration of the thumb index key pinch, restoration of the transverse metacarpal arch, correction of the little finger abduction deformity, and finally restoration of finger flexors in case of high ulnar palsy. In this video, we shall see the procedures for the correction of the claw deformity. A tendon transfer to correct a claw deformity may have to do 2 functions. One is it has to achieve flexion of the metacarpophalangeal joints, and sometimes it may also have to provide extension of the interphalangeal joints. The requirement for providing flexion of the metacarpophalangeal joints is very basic and will be required in almost all patients with low or high ulnar nerve palsy. But the need for providing extension of the interphalangeal joints also will be mostly in patients with long-standing duration of ulnar nerve palsy, with flexion of the proximal interphalangeal joint, attenuation of the central slip, and Bouvier's test negative. For more details on the Bouvier's test, kindly click on the link above. First, let us see what are the motors that we are going to use for correction of the claw deformity. We can use finger flexors like the flexor digitorum superficialis. We can use finger extensors like the extensor indicis proprius and the extensor digiti minimi. Wrist extensors like the extensor carpi radialis brevis and the extensor carpi radialis longus can be used, and wrist flexors like the flexor carpi radialis or palmaris longus can be used also. First, let us consider the use of finger flexors for correcting the claw deformity in ulnar palsy. Under this category, only the flexor digitorum superficialis is used. In fact, the Stiles Brown procedure was the first dynamic tendon transfer to be described, where one slip of each superficialis tendon was inserted into the corresponding extensor digitorum tendon over the proximal phalanx to correct the hyperextension at the metacarpophalangeal joints. This was modified by Bunnel in 1942, and the Stiles Bunnel procedure reroutes both the slips of all the superficialis tendons through the lumbrical canals and anchors them to both the radial and ulnar lateral bands of the extensor mechanism to provide a powerful flexion of the metacarpophalangeal joints. But the procedure had obvious disadvantages. Adhesion formation and conversion of the prime flexors of the PIP joints, that is the FDS, into powerful extensors of these joints, and resulted in overcorrection and intrinsic plus deformities. To overcome these disadvantages, the Stiles Bunnel procedure was modified by Littler in 1949, where he used only one superficialis tendon, usually the middle finger, for correcting the claw deformities of all the 4 fingers. The technique of this procedure is quite simple. The FDS of the middle finger is first detached from the mid finger. The end is retrieved proximally through a palmar incision. It is then split lengthwise into 4 equal slips. Each of these slips is passed through the lumbrical canal of each finger, passed palmar to the deep transverse metacarpal ligament at the level of the metacarpophalangeal joint, and sutured onto the radial lateral band of the extensor apparatus of each of the fingers. The suturing of these slips is done with the wrist in 30 degrees palmar flexion, metacarpophalangeal joints in 90 degrees flexion, and interphalangeal joints straight. The tension is checked with the wrist tenodesis effect, and after the procedure, the hand is immobilized in a dorsal blocking splint for 3 weeks. Modifications of this standard procedure have been mainly with the type of insertion. Burkhalter's insertion into the proximal phalanx, Riordan's insertion into the A1 pulley, Zancoli's lasso, where the FDS slip was looped through the A1 pulley, Omer's technique of insertion into the A2 pulley, and Anderson and Oberlin insertion into both the A1 and A2 pulleys. The disadvantages of the modified Stiles Bunnel procedure are that The superficialis transfers do not increase the grip strength of the hand, and they can also cause a proximal interphalangeal joint hyperextension deformity due to the removal of the FDS. This can be prevented by distal FDS stump tenodesis, that is, leaving behind a stump of about 1 centimeter of the FDS. But it is always safer to avoid the procedure of using the FDS for claw correction if there is passive extension at the PIP joints or in patients with high ulnar palsy and combined high, median and ulnar palsies. This is because of the paralysis of the FDP of the ring finger in high ulnar palsy, so the ring finger FDS should not be used, and paralysis of the FDS of all the fingers in high median nerve palsy. Finger extensors like the extensor indicis proprius and the extensor digiti minimi can be used for claw correction by the Fowler's technique. First, dorsal lazy S incisions are made over the index and little finger metacarpophalangeal joints. The EIP and EDM tendons are identified and divided distally. The tendons are retrieved proximally through a wrist wound. These tendons are split into 2 slips each. Each of these slips is passed through interosseous roots to the palm and through the lumbrical canals to be inserted to the lateral bands. But the Fowler's procedure has a few disadvantages, mainly because of the inadequate length of the EIP and the EDM tendons being used. Excessive tension may be placed in the extensor apparatus, leading to intrinsic plus deformities, and it may also cause reversal of the normal metacarpal arch and may also result in weakness of the extension of the metacarpophalangeal joint of the little finger due to removal of the EDM. To correct this deficiency in length, there have been 2 major modifications of this procedure. Instead of using the Fowler's for all the 4 fingers, Riordan used the extensor indicis proprius only for correction of the clawing of the ring and little fingers. Anderson, on the other hand, took 1 centimeter of the extensor hood also to provide an increased length. The wrist extensors play a very important role as tendon transfers for correction of the claw deformity. The extensor carpi radialis brevis and the extensor carpi radialis longus are used in different procedures like the EE4T, EF4T and the EF5T. The EE4T procedure, or the extensor to extensor 4-tailed graft, was described by Paul Brand in 1961. The technique of performing this procedure is as follows. The ECRB tendon is first divided at the level of the wrist. It is extended with 4 tendon grafts. It then goes from a dorsal to palmar route through the intermetacarpal spaces. It enters the lumbrical canals and runs volar to the deep transverse metacarpal ligament and is then inserted to the radial lateral bands of the middle, ring and little fingers and ulnar lateral band of the index finger, which is not shown in the diagram. The main advantage of this procedure is that it can be used for combined ulnar and median palsy. This procedure has a few disadvantages. Re-education following this transfer is difficult, and wrist extension slackened the graft so that the patient had to learn to avoid wrist extension while activating the ECRB transfer, and because tendon grafts were used, adhesions were common. To overcome some of these problems, Brand himself described another procedure, the EF4T procedure. This is an extensor to flexor 4-tailed graft. The donor tendon here is the extensor carpi radialis longus, which is extended by tendon graft, which could be palmaris, fascia lata, plantaris, and even the ECRL turn down flap as described by Malavia. The ECRL is divided at its insertion. It is retrieved 6 to 8 centimeters proximally in the forearm and lengthened with the graft with careful attachment so that the bare tendon is not exposed and epitenon covers each of the suture lines of the graft and the ECRL tendons. Next, a mid-palmar incision is made. A long tendon retriever is introduced into the palmar wound and passed dorsal to the superficial palmar arch through the carpal tunnel deep to the brachioradialis to the forearm incision, and the graft is retrieved in the palm. This tendon graft is now split into 4 tails, and each tail is passed through the lumbrical canals of the fingers volar to the deep transverse metacarpal ligament and sutured to the lateral bands, that is, the radial lateral bands for the middle, ring and little fingers, and ulnar lateral band for the index finger. This suturing is done with the wrist in 45 degrees flexion, metacarpophalangeal joints in 70 degrees flexion, and interphalangeal joints straight. An alternate position would be to keep the wrist in neutral position, metacarpophalangeal joints in 90 degrees of flexion, and interphalangeal joints straight. The advantage of the EF4T procedure is that it is mechanically more efficient. The disadvantages of the EF4T procedure are that a graft is needed, so adhesions can develop. The transfer sometimes restricts wrist extension, and there is a danger of injuring or compressing the median nerve in the carpal tunnel when the graft is brought through. The Palande's EF5T procedure is a modification of this procedure. It is sometimes known as the intrinsic reactivation procedure. It was described by Dinkar Palande in 1983. Along with correcting the claw deformity, it also corrects the reversal of the metacarpal arch. As said earlier, it is a modification of the Brand's EF4T procedure and uses 5 tails. So it is an extensor to flexor 5-tailed procedure. But each tail is not attached to the lateral bands like in the Brand's procedure. First, the ECRL tendon is harvested. It is lengthened with the tendon graft, usually fascia lata, tunneled to the wrist and retrieved at the level of the wrist. Now a distal palmar incision is made at the level of the distal palmar crease, and the hypothenar, lumbrical and interossei muscles and tendons are dissected. The fascia lata graft that has been retrieved at the level of the palm is now split into 5 slips. The pairs of interosseous tendons, that is one palmar and one dorsal, are identified and tied together with non-absorbable suture. When this is pulled, we will note that there is adduction, and on relaxation there will be abduction of the adjacent fingers along with flexion of the metacarpophalangeal joints. The 3 middle slips of the tendon graft are looped through this construct. The lateralmost tail is sutured to the first dorsal interosseous, and the medialmost tail is sutured to the hypothenar muscle tendon junction. With the wrist in neutral and metacarpophalangeal joints in 55 degrees of flexion with the interphalangeal joints extended and the little finger carpometacarpal joint flexed, and immobilization is done in the same position for 3 weeks. The advantages of the Palande's EF5T procedure are that it gives an equal result as in Brand's procedure for correction of the claw deformity. It provides an increase in the grip strength of the hand. The incidence of proximal interphalangeal joint hyperextension is reduced as the FDS is not disturbed, and the transverse metacarpal arch is also restored. The wrist flexors also can be used for correction of the claw deformity, and the tendons that are used here are the flexor carpi radialis or the palmaris longus. The use of the flexor carpi radialis for correction of the claw deformity was described by Riordan in 1969. It is actually ideal for patients with long-standing claw hands who habitually flex the wrist to attempt to extend their clawed fingers, that is the tenodesis maneuver. So along with correction of the claw deformity, the FCR transfer also corrects the wrist deformity and the swan neck deformities. The technique of performing this transfer is as follows. The flexor carpi radialis tendon is divided at the wrist and retrieved proximally. It is lengthened with a graft. It is then passed subcutaneously around the radial metaphysis to the extensor side of the forearm. This graft is split into 4 longitudinal strips. It enters the palm through the intermetacarpal spaces, runs through the lumbrical canals, volar to the deep transverse metacarpal ligament and attached on the radial lateral bands of the involved fingers. The obvious disadvantages of this transfer are: if it is a high ulnar nerve palsy, it is contraindicated as it will remove the only wrist flexor. Ernest Fritchie, on the other hand, suggested using a weaker tendon for transfer like the palmaris longus, and this he described in 1971. Though the palmaris longus is a weak muscle, it is useful in younger patients with supple hands, and it can be used in all patients with well-developed palmaris longus tendons and hypermobile or mobile hands on the basis of less donor morbidity. The palmaris longus is divided at the wrist and withdrawn in the proximal forearm and extended with the tendon graft. Sometimes, like in a Camid's transfer, the palmar aponeurosis can also be dissected along with the palmaris longus to serve as an extension of this tendon. It is then passed through the carpal tunnel and inserted on to the lateral bands or the intraosseous tendons as described by Palande. Therapy is important after every claw correction procedure. Immobilization of the hand is done for 3 to 4 weeks according to the institution protocol. The wrist is kept in neutral position, the metacarpophalangeal joints in 90 degrees of flexion and interphalangeal joints extended. Active movements are started after removal of the POP at 4 weeks. The claw correction splint needs to be worn as support during therapy, and finger straightening splints can be used to concentrate the pull of the transfer tendon on flexion of the metacarpophalangeal joints. Avoidance of heavy gripping and work needs to be done for a minimum of 12 weeks. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see the other parts of management of ulnar nerve palsy like the nerve surgery and the static procedures. And do not forget to subscribe to stay connected with the latest in learning hand surgery.